Drug-induced cough. I am just coming to this again and again. Yes, we all know about AC inhibitors. From the medical school, we are hearing that. And at the moment, we all know we are not using that much of AC inhibitor. But yes, with some patient as AC inhibitor, some of them are much cheaper than A2 receptor blocker. We can use or we have to use. But 20% of the users can develop cough. And interestingly, this cough might develop few months or even an year after. Now, in these cases, patient might not think that it is important for you to know that they are on some cardiac drug. Because in our country, the patient choose their doctors and they just think that these are the medicines we are using for chest. These are the medicines we are using for heart. So it is not important for this doctor to know. And also, sometimes I also get confused with the trade names. So many trade names are coming and it's, say, I'm just giving an example, Ramipril. The trade name something might not just sound similar to Ramipril at all. So you might not know. You have to check in Google or something to BIMS or whatever to find out what is the composition of that drug. So that is important. And when you just change the drug, you cannot just stop an antihypertensive. You can change the antihypertensive to something else. So maybe you have changed it to something like telmisartan or losartan. This cough may continue. Some patients, in most patients, I would say, they stop by 2 to 4 weeks. But the studies are saying it can stay up to 1 year. So you have to educate the patient accordingly. Now, can you see in this presentation, there are few things which are very important. Now, we think it is a GERD, and we are giving them, pantoprazole is a very commonly used drug, and omeprazole as well. When we started with this PPIs, that was the most favorite of people. Nowadays, this either rabiprazole, pantoprazole, and newer prazoles are in the market. But there is evidence that omeprazole and pantoprazole both can give to this chronic cough. So think about it. Statins, a lot of patients are on statins nowadays. So again, a thought. Sitagliptin, again, a thought. Insulin glargine. This is important. Now, the other drugs we use, leflunomide or opioids, interferon and ribavirin, or recombinant DNA drugs like glargine or sacubitril, valsartan. The list I have given, all of them can cause. The dilemma is, shall we stop this drug if the patient is having cough straight away? The answer is no. You have to come to a diagnosis first and also work on the common things first. Okay. In one lecture, we have heard that sitagliptin gives rise to cough. So stop sitagliptin. I'm not saying so. What I'm saying that these are the drugs which we commonly being used. They can give cough. So sometimes it happens that if you can shift it to something else, then you can give it a try. And we say that stop the medicine. Say if a patient is on statin for some very normal lipid profile, but their blood pressure is high. That's why they are on statin and they are coughing. And you couldn't find anything on investigations and nothing is working for them. So you stop statin for 3 to 6 months and see whether the patient is improving. Now, if they are not improving, then definitely statin is not the culprit. You can restart the statin. If it is giving them problem, you stop and think about something else, because cough is really a bothersome symptom for the patient. So whenever you are giving a medicine to a patient, you have to think about the pros and cons. So guidelines are saying this, yes, we know, but is this drugs according to the guideline is giving some other problem to the patient? Because say cardiologists are starting them on statin, patient might not be willing to even stop the statin if you want them to stop, but you have to deal with the patient with some kind of understanding that what they believe and what they think and what you think at the end of the day.